Now we're on. Good. The Biden Cancer Initiative, American Cancer Society Cancer Action Network, American Society of Clinical Oncology, Association of American Cancer Institutes, the Prevent Cancer Foundation, St. Jude Children's Research Hospital, and the Union for International Cancer Control. In the briefing packet, there is a page which 28 organizations and another 40 by the Secretary of Health and Human Services, Alex. Research advances, especially the development of an amazingly effective vaccine, which we'll hear about from the key developer, Dr. John Schiller, and his partner, the acting director of the National Cancer Institute, Doug Lowy, have brought us to the point where it's actually feasible to prevent these HPV-related cancers and combine with screening and effective treatment for those that can be early diagnosed to progressively eliminate this scourge on the human population. So of the 570,000 worldwide, we estimate 34,000 in the U.S. To make this progress, we have to mobilize physician care professionals, those interested in school health, to really make a difference. Very, very appropriate topic for the Congress. And I told her that I remember when she was elected, because she has been recognized as a tireless advocate for increases in NIH cancer research funding and has made a profound impact on cancer prevention in Florida by initiating of the HPV vaccine. Her HPV awareness campaign began 6 years ago. She noticed that Florida had one of the lowest vaccination rates in the nation. Since then, she has seen an increase in HPV vaccination rates in Florida. Maybe she'll tell us about this. And we are just thrilled to have your leadership, your support today, and your presence and your comments right now.
Well, good afternoon, everyone. I am entirely optimistic that we are going to be able to eliminate HPV-related cancers. I'm optimistic. I tell you, this turnout today makes me very optimistic. That means that all across Capitol Hill, offices are engaged and ready to take this on. So thank you for being here. I'm also know that the HPV data out new effectiveness of this vaccine devoted their professional careers to eliminating cancer and finding the treatments and cures that make our families safe and well. Especially inspired by my good friend Dr. Anna Giuliano from Tampa's Moffitt Cancer Center. She has taught me all along the way. And just to tell you a personal story, one of the reasons that we began an HPV awareness campaign in the Tampa Bay area a few years back was, yes, I saw that the Florida uptake rate was very low. But it was also because I was a young mom with 2 young daughters, and always, I work on health policy. Of course, I should make sure that my own daughters are getting the HPV vaccine. Back then it was 3 doses. And I dropped the ball. And I missed a dose that they should have had. My youngest daughter, she really doesn't like shots. But I couldn't believe that with every blessing I have in my life and all the knowledge I have about how important that is, that it's not easy. And for a lot of working families and a lot of families who don't have access to routine health care, there are barriers out there. And what a terrible thing that is, that if you don't get the vaccine, you could be diagnosed one day with cervical cancer, one of the other cancers. So the nice thing about being a member of Congress is you can do something about it. And we did. And we're not going to stop there, because now we have the tools at our disposal to eliminate these cancers and save lives. And that's what we intend to kick off. We are going to marshal all of the forces here in a bipartisan way across Capitol Hill to bring legislation that can pass that will help meet Secretary Azar's endorsement of the WHO goal to eliminate these cancers. We can do that. And every one of you has a role to play in that. So listen to these folks today. We will be listening. We'll be drafting legislation. I need all of your bosses, all of your offices, all of your advocacy organizations to join us. There's one thing I wanted to mention, though, because I was looking again at the uptake rates across the country, and just to check again where Florida is. Unfortunately, Florida is still near the bottom. But a lot of the states that did not expand Medicaid are clustered there at the bottom. So we've got to work on that as well. But I wanted to mention that as we focus on what barriers exist to making sure that families have access to the HPV vaccine and everything that we can do to keep our families healthy and well. So thank you, each and every one of you, for what you've done so far. And we're going to use you as inspiration to get legislation drafted, passed here on the Hill, and eventually eliminate all HPV-related cancers. We can do this. I'm confident. Thank you very much.
Well, thank you for those inspirational comments, for all you're doing, and for pointing out that everything is connected. You know, today the theme is prevention, but having coverage for health care under Medicaid and under Affordable Care Act is actually critical in our health care system, that people have the coverage in order to get the care and the preventive interventions that work and that they need. Okay, we now have a special video from an organization called Survivor. How would you spell Survivor? There it is. It's rather clever. Advocacy group for women. The founder and CEO, Tamika Felder, is you. Welcome. She has given us permission to share this story of one of their members, Lisa Moore, who unfortunately died from cervical cancer, but wants to have her message carried as widely as possible. And this is how we can do it.
My name is Lisa Moore. I'm 30 years old and I live in South Bend, Indiana, and I was diagnosed with stage 1B1 adenocarcinoma of the cervix at 26. No one deserves this. Bowel obstructions are not fun. Neph tubes are not fun. Tubes in your stomach aren't fun. The side effects of the treatment are not fun. If something like this is preventable, I don't understand why people don't want to prevent it. If it was a leukemia vaccine or breast cancer or prostate cancer or anything not related to sex, there'd be no question. Cancer sucks. It takes and takes and takes. And majority of the time, it takes everything and kills you. If I can help somebody else not go through this, that's probably the best thing I have to offer at this point.
Lisa asked that her story be shared. Hope it has meaning, deep meaning for all of us. That HPV vaccination lives, like dying of cervical cancer per year in the United States. Please join me in a moment of silence for Lisa and all those who have. Thank you. Now we turn to Juliana. She's the founding director of the Center for Immunization and Infection Research in Cancer at the Moffitt Cancer Center in Tampa. HPV-related cancers.
Great, thank you. Oh. Well, this is an absolute pleasure for me to see so many people here. As you can tell, this is a very strong community of people who are like-minded, who all believe that we can actually accomplish this goal. And it's just so wonderful to see all of you joining us in that. What we have to remember, and this is a number that I think is really significant, that every 2 minutes, one more woman dies of cervical cancer in the world. Every 2 minutes. This is a cancer that is completely preventable. So we are talking about every 2 minutes, a woman is dying from something that she should not be dying from. So what is causing that cancer? Human papillomavirus is a common virus. This is an equal opportunity virus. So you're going to hear this over and over and over again. This is not just certain groups. This is all of us. All of us who are sitting in this room have been exposed to HPV, and at one point in our lifetime, we will be infected. What we don't know is who among us is going to develop that cancer. In fact, this is such a common cancer, it's such a common virus, that 1 in 20 cancers worldwide are actually caused by HPV. So it's not just cervical cancer. As you heard, there are up to 6 different cancers that we know of, and there may be more, but right now we know that there are 6 that are caused by human papillomavirus. In the United States alone, it costs us over $10 billion in healthcare dollars every year to diagnose and to treat the diseases that HPV causes. So what are those other cancers that HPV causes? So you can see here, at the center is the virus, and you see at the very top is cervical cancer, which is the first cancer that we believe we can actually eliminate. And over time, if we are effective in getting vaccine coverage where it needs to be, we can likely see prevention and ultimately elimination of the other cancers. There's one I want to particularly highlight here today, and that's a subset of head and neck cancers. The head and neck cancers I'm talking about are those that affect the base of the tongue and the tonsils, or we can just say the throat cancers. In the United States, around 80% of those cancers are caused by HPV. And this is a cancer, actually, that mainly affects men. So what you can see for the US data that we have is that with screening and treatment, we've been very effective in controlling the incidence of cervical cancer. We haven't gotten to 0. And you can see that line at the very top, which is a straight, bold line, is the steady decline that we're seeing, but it has been a slow and painful decline of a cancer that is completely preventable. But what you see at the bottom in the dotted line is a significant increase in oropharyngeal cancer that's affecting men in this country. In fact, that increase has been so dramatic that in the last 15 years, there has been a doubling of the number of men who have been diagnosed with HPV-related oropharyngeal cancer just in the United States. So when we use these words, control and eliminate, I just want to make sure that we're all on the same page. Control is reducing a cancer incidence to some acceptable level. And we can all, each country will define what is acceptable. So you kind of see that slow decline in cervical cancer incidence that I showed you. But elimination means getting to near 0 of that disease. And that's what we're talking about. What we're trying to achieve is actually, hopefully, never to see these cancers again. Now, that is a huge accomplishment. We can't. This is the one opportunity we have to actually see a cancer disappear. So to eliminate cervical cancer, what is it going to take? Well, it means to the US programs of screening and treatment that we currently have. By adding vaccination, we can accelerate that drop in the incidence of cervical cancer and really try to get to that word that we all care about, which is eliminate. In fact, the scientific community is so strongly behind our ability to do this with the tools that we have that last year we saw Dr. Tedros for the World Health Organization make the statement that it is time to end made a call to all communities in the world to join the forces to make that a reality. Here in the United States, last year, we saw all of our NCI-designated cancer centers join forces and say, we agree. It is time to end HPV-related cancers, starting with cervical cancer. And you can see that all the major cancer organizations have endorsed that statement as well. There are several countries that have already declared that they're going to be the first. Do you think we should be the first? Well, we see Australia. They're making really strong claims. We see Canada, our friends to the north. And we even see our friends from sub-Saharan Africa in Rwanda saying that they will accomplish that goal. So the call to action is the United States needs to get on board, and we need to accomplish this goal. We can set that example. We have the tools to eliminate cancer. We have the knowledge. That's not going to be enough. We have to apply that knowledge. Willing is it's not enough for us to sit here and say, yeah, I think I want to do that. We have to have action, and that action is going to require all of us.
Very good. Well, there was one phrase that was very unsettling there, which was reducing the cancer incidence and cancer mortality to an acceptable level. Of course, we want to reject the notion that there's an acceptable level, and that's the mission here, where we actually have the tools to do it. Okay, thank you very much, Anna, for giving us this introduction about HPV cancers. It really is an unprecedented opportunity to move aggressively on these cancers. Our next speaker is Dr. Julie Torode. She is the Director of Special Projects.
UICC. What we see in maternal deaths internationally is that we're actually also crossing that 300,000 barrier, but in the other direction. And that really begs the question. We've put so much effort in global health to improving maternal survival. What is the point of doing that if that same very woman then dies of cervical cancer? We've been investing so much in improving access to HIV treatment. What is the point if that same years later of 100,000? So whilst we sit here in the US and think cervical cancer is quite a rare cancer, in those countries, women know exactly what cervical cancer is. They know what it means to die of cervical cancer with little or no access to pain relief. They know what it causes in stigma and ostracization in their communities. And I'd just like to give you a few pictures of a story in Vietnam. This is a woman that spent 2 days getting to a health center for access to help for herself and her child. She also has other barriers. Maybe she's not the decision maker on accessing health in her family. Maybe it's the husband that decides whether she can make that journey. Maybe there are religious and cultural beliefs that mean that she doesn't get the help to access those services. If she does get to a health site, she may have to wait many hours, even days, to get to see one of the few specialists that can help screen for her cancer. And I really like this photo because you can see the thoughts of the women as they're sitting there waiting. Maybe they're thinking about the fact that they've left their other children at home, that their businesses, that their fields are not being tended, their livestock is not being looked after. They're worried about what they might hear when they see the doctor and whether that might mean that they have to pay for care that they know they can't afford, seeing many people really moving into catastrophic expenditure and increased poverty because of a cancer diagnosis. And we know that 4 out of every 5 women diagnosed in a low-income setting is likely to die of cervical cancer. But already we have good care in some countries, and I love this photo of the care being shown of the women that are dying. So WHO has a life course approach to cervical cancer. Anna showed that three-leg stool of prevention, early detection, and treatment. There's guidelines in each of these areas. There are global indicators connecting cancer to NCDs, non-communicable disease global action plans, to HIV action plans, to child maternal health action plans. There's global advice around the best buys in global health, cost effectiveness recommendations that say these are the priority actions for any country. And all countries have signed up to these action plans. And we also know that particularly women living with HIV need to be of high focus because they're the high risk of developing cervical cancer. So the clear question is, what are we waiting for? We've got all of this guidance in every global strategy. So why is that map still very much showing the global divide? Well, I think the answer is leadership. What we have in Dr. Tedros is someone who is putting their necks out. He is standing up and calling for action as in his role as Director General of the World Health Organization. And UICC and others were more than happy to join that call to action in 2018. And I put that up just to show all of the UN agencies and other partners that are very much behind this. So it's very much a multi-stakeholder attack on this cancer. And we've got a quote there, we have the tools to prevent cervical cancer. And he's really trying to call for global coordination, really to put cervical cancer in the history books. So we really need to support Dr. Tedros in his efforts. We talked about member state commitment. Following that call to action, there is an executive board meeting in January. This was championed by Australia to take this to member states and put this challenge before them. And 70 countries spoke out in support of this initiative, particularly countries with the high burden. It was unprecedented that this small decision at the WHO Executive Board was supported by 41 countries. It was really showing wide geographical support for this. And I have to say, the US signed up, so you've got an open door there. And we have had those public commitments for elimination to their own populations from Australia, Zambia, Malaysia, Kenya, Bhutan, Rwanda, just recently Canada. So let's hope that we can follow with US very soon and really get this moving. So let's take a quick deeper dive into what is that emerging global strategy, because the decision was to task WHO with crafting a strategy that would be consulted upon in the course of the next few months and then taken back to World Health Assembly in May next year. So this provides a great window for a US announcement in May, at the latest, I would hope. What it is in layman's terms is a uniting behind the vision of a cancer-free world, and who can object to that? The threshold that's being defined for elimination is to take the number of cases down to 4 per 100,000 women in every country. What does that mean? You know, we've been talking a lot about numbers, but I think to put that in context for you, the definition of a rare cancer globally is 6 per 100,000. So what we're saying is we want to take cervical cancer rates below the definition of a rare cancer to really eliminate the problem. It's very much connected to the 2030 agenda. That's where we're working towards as a global community, the Sustainable Development Goals. And in fact, cervical cancer is already anchored in that. Reduction globally in cervical cancer mortality by 2030. So we're very much aligned with the initiative. This is not new. This is just creating a new momentum for an already signed off agenda. What I like about the targets that expert opinion has helped WHO develop is the focus on coverage, the focus on equitable access and equity in outcomes, because that is what is going to get these rates down. So we're asking all countries to go for 90% coverage in vaccination of girls at least by age 15. We're asking for screening programs to reach at least 70% coverage with 2 screens at a minimum in a lifetime at the right age between 35 and 45. And 90% coverage of follow-up of any positive cases. So follow-up of any pre-cancers so that they can be treated, or follow-up of any cancers so that every single woman has a chance for the best outcome possible for her. The mantra of the SDGs is to leave no one behind. And I think this agenda is very much aligned, leaving no woman behind and also making sure we leave no country behind, particularly those with the highest burden. Just a short story to show you why those numbers have come out. If you look at that blue curve at the top, you can't really call it a curve, actually. It's a very gentle line This is our impact on the global burden collectively as a community. That line is heading off down that way. It is not going down towards lower levels of cancer, cervical cancer incidence. How do we bend that curve? By upping our impact. Looking at intensifying just vaccination. Yes, we bend the curve, but look to see when it's starting to bend. It took 30 to 40 years to start to impact in terms of lives saved. But when we add in screening, look how much earlier that impact starts to happen, how much quicker that curve starts to come down, and look how much lower we get as far as getting to those levels of which we can say we've hit elimination. And what about those lower income countries where the challenge looks so enormous? Well, this is a quote from the Brazzaville consultation that I joined with some of our members just last month. It was a consultation on the strategy which WHO is taking to different regions. And this is a quote from someone in the room. 90, 70, 90 is challenging for us in Africa, but we will uniquely benefit from elimination. So it's great to see the enthusiasm to try and get behind this in the African region, and we hope that we'll see that in all of regions as they consult with WHO. I'm just finishing now very quickly on three key messages for me. There's an opportunity to empower women and really engage our communities. This is a photograph from a woman in El Salvador talking for the first time with her peers in her village about her experience. You can see she's talking from the heart and the emotion in her voice to really try and engage people in prevention as well as cure. What about treatment? People say that's too big a challenge in low-income countries. I would say that's not the case. We are tracking cancer plans as UICC. More and more countries have that leadership in cancer control. 158 countries now have comprehensive cancer plans, and they include cervical cancer strategies. So yes, I think it's time to focus and use cervical cancer to really implement those plans. And finally, just on the note for leadership in innovation, we talked about the role of the HPV vaccine. It's a new innovation. It was first registered in 2006, first taken up by Gavi as a key vaccine in 2009. But look how many countries are already rolling out vaccination. By 2021, the commitments are really starting to impact in those countries where we see the biggest need. So I think an important leadership role in continued innovation and research is so important. So I'll leave it there because that's where John's going to pick up. And thank you for your attention.
Thank you. Full view of this is very important for the context.
As it tries to infect you and prevent that infection. But it's not at all like the virus in the fact that it doesn't have the genetic material of the virus. A little bit of this that they really have dramatically reduced the incidence or the prevalence of the target HPV infections to go away. So we say that's why it's critical that we focus vaccination on young people before they become sexually active. Now, contrary to what you did on the internet, and funded the research that led to the discoveries of the vaccine and also led in some of the initial clinical trials. But then there was a handoff to industry to do what they do best, to produce large amounts of the vaccine, test it, get FDA approval, and then go on and manufacture and sell the vaccine. And now we're in the phase where another government institution, the CDC, is providing the vital contributions to monitor uptake and impact of the vaccine. So what is limiting the potential of this vaccine? I hope you've heard a lot about this, that this is a great potential intervention. Why isn't it preventing more cases of cervical and other cancers? And the issue is limited uptake. But what's interesting is that the reasons for limited uptake are different in high resource settings and low resource settings. In high resource settings, the main barrier is acceptability, okay? Vaccine hesitancy. The vaccine is available to most people in the United States, but we still have coverage rates in the 60s rather than the 80s or 90s that's recommended. Whereas in low and middle income countries, the real problem is accessibility. They actually are very well accepted when they can get their hands on the vaccine, 80% coverage rates the first year, but they just can't get the vaccine. Now, why is this? There's really two main reasons. The biggest reason is that it's an relatively expensive vaccine, and implementation programs, especially 2 or 3 doses in adolescents, is just expensive, and they can't afford it. And the other thing is that there's a looming vaccine shortage, which is going to be manifest over the next 5 years. Over the next 5 years, we may be 30% or 35% of the young girls who would otherwise be vaccinated are not going to be able to be vaccinated because we don't have enough vaccine. Now, it's important in the United States, $5 in the United States and $5 in the developing world. So what is the potential impact of this vaccine? Recent WHO data where they look at the cohorts that were eligible for vaccine over the last few years since 2006. And what they estimate is that in a non-vaccine so far, after 10 years of having an HPV vaccination available, and it's actually quite discouraging because we've only prevented about 360,000 cases and 150,000 deaths. And if you look at the stripes, it's pretty obvious where these preventions are occurring. They're occurring in high resource settings because those the individuals who are getting the vaccine. There's almost no dent yet in low income settings. So that's the problem, but are there any potential solutions on the horizon? And let me just address this briefly about ways that we could possibly increase uptake and impact of this vaccine. I'm going to focus on the primary target of this vaccine, which is 9 to 14-year-old girls, because cervical cancer dominates. It's about 85% of HPV-associated cancers worldwide. And we think by far the thing that could make the biggest impact is to transition to a single-dose vaccination program. Now, this is completely unheard of for a subunit vaccine. There's no subunit vaccine that's given as a single dose. So why do we think that this could potentially work? It's because in post hoc analysis, after the fact analysis of an NCI-sponsored clinical trial, and later one that was sponsored by WHO in India, women who just happened to get one dose for various reasons, they're not getting HPV infections any more than are women who got the prescribed 3 doses. In the NCI trial out to 11 years, they're not getting any more infections, and they're also still maintaining strong antibody responses. But this, what we call post hoc analysis, is insufficient to convince regulators that we need to change to a single dose. And so the NCI has embarked upon a large-scale clinical trial to formally, in a randomized controlled trial, compare the efficacy of 1 versus 2 doses. Fortunately, these trials take time, and the data won't come out until 2025. The peak of the is over. Another thing that the WHO is contemplating is to suggesting in places is in shortages is to delay the second dose. Okay, rather than give it 6 months, so if you vaccinate a 10-year-old, rather than give the next dose within a year, let's wait 3 to 5 years until there's more vaccine to give them their second dose. And although the data isn't completely strong, there's good suggestions that that would be an effective way to do things. Another thing that could help is to temporarily curtail introduction of new male and mid-adult vaccination programs, and also the transition from Gardasil 4, which is not used in the United States. We just have Gardasil 9, okay? But we should maybe delay transition to Gardasil 9 from the countries who are still getting Gardasil 4, because it takes 2.5 times more of the vaccine components in manufacturing capacity to make 1 dose of Gardasil 9 than Gardasil 4. And the other thing we look forward to is generic vaccine manufacture in middle-income countries, particularly in India and China. And I'm happy to say that we think that the first generic vaccine made in China is probably going to be approved for distribution in China, although not other countries, in this calendar year. So there are other priorities of research into elimination. I don't have time to go into these, but just to list them, there certainly is interested in therapeutic vaccines because the HPV vaccine doesn't make the infections or the lesions go away. And there isn't any commercially available, but there really is a gratifying amount of activity, both in academia and importantly in industry, to try to develop vaccines to treat persistent HPV infection all the way to cancer. We desperately need better treatment options, and we need them not only for cancer, but also for persistent infections, which more and more are going to be identified in screening programs. And lastly, we need improvements in screening to make them more accessible in low-resource settings for cervical cancer screening, and we also need them in all settings for other HPV cancers. We don't have in-place screening programs, for instance, for anal cancer or oropharyngeal cancer. So let me wrap up here by saying that U.S. government-sponsored research was really the key for establishing the critical role of HPV cancers in developing these highly effective vaccines. We actually stand here today with the tools to eliminate cervical cancer. We can't say that about any other cancer. And for someone who's been studying this virus and developing this vaccine for 35 years, it's incredibly frustrating that we don't have higher impact due to limited distribution and uptake. But that doesn't mean there still isn't things that we can do. And based upon, we still need further research to increase the rapidness of elimination, importantly, the equitability of elimination, and the cost effectiveness of elimination by doing continuing research. So thank you very much.
Thank you, John. There was quite a tutorial about a very, very complex and successful research endeavor over, as you said, 35 years. And the research agenda is still full of plenty of challenges, very important challenges. On the other side, there's a lot of practical decision-making, supplies and costs and dosage, things that really do involve people far beyond the research lab to figure out what's the optimal way in different settings to make the greatest benefit from this amazing vaccine. Now let's turn to the CDC, the Centers for Disease Control and Prevention. Prevention is our theme. First speaker is Melinda Wharton, Director of the Immunization Services Division, the National Center for Immunization and Respiratory Diseases at CDC.
Thanks so much. I really appreciate the chance to talk to you today. I'm going to start with the timeline of our HPV vaccine recommendations in the United States. In 2006, HPV vaccine was recommended routinely for girls at ages 11 to 12 as a 3-dose series, and in 2011, that recommendation was extended to include boys. In 2015, the 9-valent vaccine replaced the 4-valent vaccine, and in 2016, the recommendation was changed to a 2-dose series for those who start the HPV vaccine series before their 15th birthday. So how are we doing? Well, not as well as we should be. In the United States, we monitor vaccine coverage at ages 13 to 17 years through CDC's National Immunization Survey. Now, in 2006, there were 2 other vaccines that were also recommended for routine use at age 11 to 12 years, and those are the top 2 lines on this graph. That was the tetanus, diphtheria, and acellular pertussis vaccine, or Tdap, which is the top line in red, and just below it in blue, the meningococcal conjugate vaccine. Since 2006, both increased coverage steadily and are now both well above 80%. Contrast that with where we are with HPV vaccine, which is the orange line kind of in the middle of the graph. On this graph, we're showing coverage for HPV vaccines starting in 2011, which is the first year the vaccine was recommended routinely for both boys and girls. The gap between that orange line and the two lines above it is our failure to deliver all recommended vaccines to every child in this age group who had an opportunity for vaccination but didn't get all the vaccines that were recommended. Coverage with the full series is even lower. You can see in the yellow line below when we had the 3-dose recommendation, or the turquoise line in 2016 to 2017 with the 2 or 3 dose recommendation for the full series. That we still have a lot of progress that we need to make. In 2017, 66% of adolescents aged 13 to 17 years of age had received at least 1 dose of HPV vaccine, and 49% had received the age-appropriate full series. Although coverage has been increasing, it still remains far short of the Healthy People 2020 goal of 80%. There also continues to be substantial variation in coverage by state. In 2017, full series HPV coverage ranged from 29% in Mississippi to 78% in the District of Columbia. In the National Immunization Survey, we ask parents of unvaccinated adolescents why their child isn't vaccinated. In the 2017 survey, one of the most common responses was that the vaccine had not been recommended by their child's health care provider, and this is always one of the top 5 responses. But if we look at the other recommendations or the other reasons cited by the parents, it seems like many of them might have been addressed by a strong provider recommendation and the provider's willingness and ability to answer a few questions that the parents might have had. In surveys of pediatricians and family physicians, immunization providers acknowledge that they do not consistently, or they don't all consistently, give a strong recommendation for HPV vaccine at the recommended ages of 11 to 12 years. Now, even though coverage is not as high as we would like it to be, there is already impressive evidence of the impact of HPV vaccine on several different outcomes. Here are data from CDC's National Health and Nutrition Examination Survey, which shows the prevalence of vaccine-type HPV in young women by age group during the 4-year period before the vaccine was introduced, compared at each age group with the 4-year period after the vaccine was introduced. And you can see in the first pair of bars a really substantial decrease in the prevalence of vaccine-type HPV in the youngest age group looked at, those 14 to 19 years of age, in that first 4-year period after the vaccine was introduced, even though vaccine coverage was really kind of embarrassingly low at that time. So already we were seeing that degree of impact, which is remarkable. In the more recent period, from 2011 to 2014, we see continued reductions in the prevalence of vaccine-type HPV, not only in the 14 to 19-year-olds, now down by 71% compared to the pre-vaccine period, but also a decrease of 61% among those 20 to 24 years of age. These data are really encouraging and are consistent with the reductions we're seeing in other outcomes, including HPV precancers. With on-time vaccination, we can prevent HPV infection in young people. And if we prevent infection, we can prevent HPV cancers. Thank you.
Thank you very much, Melinda. Critical data, a lot to be done, clearly feasible. Our next speaker is Vicki Bernard. She is the chief of the Cancer Surveillance Branch, Division of Cancer Prevention and Control at CDC.
Thank you. So you saw Anna showed the stool with the 3 legs, and we need to have all 3, vaccine, the screening, and treatment. And today I'm going to talk to you more about the screening and treatment. I love the slide that Julie showed about the decrease with just the vaccine, but when you add in the screening and treatment, how much quicker we can get to that. So we know that we've seen cervical cancer rates decline over the last several decades, and this has been since the introduction of the Pap test in the 1950s. Here, this graph shows in 1975, that went down to about 2 in 2015. But what you see here is this leveling off here in about 2007. Rates are showing is that there are higher rates of cervical cancer in African American women and Hispanic women, women living in non-metropolitan areas, as you see in the graph on the right. The higher line shows that more deaths are occurring among cervical cancers in the non-metropolitan areas compared to the metropolitan. Women with lower socioeconomic backgrounds are dying and getting this disease more frequently. And I think what's astounding is that women with cervical cancer have not been screened. Over 50% of women with cervical cancer have not been screened. So who's getting screened, who's not? This is just a snapshot by the, across the U.S. where we see screening rates vary from 65%, that's in the lower color, to 85%, which is in the darker color. But no state has reached the Healthy People 2020 goal of 93%. And we know that that screening rates vary in foreign-born women, women with lower education, higher poverty, uninsured, underinsured women are just not getting screened. We also know that treatment is not similar across the board. Here, this is just a quick snapshot of looking at the guidelines for treatment for cervical cancer. And if you look by race, we see that white women are more likely to get treated according to guidelines compared to Hispanic women and black women. We need to do a better job here of making sure that all women are given the same access. So over the years, we've seen these common barriers around prevention, around treatment, around follow-up, around screening. We see individual factors, provider factors, system factors. But for the individual factors, just awareness alone, women don't know that there is an HPV association with the cervical cancer. I just completed a study where we talked to over 400 women, and half of them had not been screened. And we asked why. They said, I just didn't know I could get cervical cancer. That was the highest response. Almost 80% of these women said, I just didn't know I could get cervical cancer. They don't know what the PAP's for. They don't know it's screening for cervical cancer. We can do a better job just educating women that any woman can get this disease. Providers, just any opportunity you can to talk to the woman, to ask her about screening. Take every opportunity. And then system factors in the United States. We know our system is broken. Access to health care, uninsurance. We don't have a tracking system of who's getting screened and who's not. We know that reminder systems work, but yet we can't get it when we're in and out of different health systems. We do have a surveillance system that does track our HPV-related cancers. So we are able to determine who's getting cancer and who's getting cancer more frequently. So using these systems that we have, the CDC funds the National Program of Cancer Registry, where we're able to collect all cancers. Cancer is a reportable condition. We also have a new screening tool where you can click on and get all of the HPV-related cancers. This looks at it by this graph here. We also have it by the state and by demographics, so you can quickly link on and get the numbers for your state. But we need to use these numbers more. We need to link with vaccine programs. We need to link with screening programs, with claims data. How can we really target interventions to women that need it? Thank you.
Having just heard the two talks from the CDC about population data in the United States, it's probably worth mentioning that there's a major medical article published today in the British journal called The Lancet about results in 14 high-income countries from immunization campaign against HPV infections. And what they document in very dense article, but very useful language, is that there is substantial success in reducing the incidence of infection, similar to what we just heard. There is success in reducing the incidence of genital warts, which are a non-cancer lesion. That's a clue about the disease. And there is a reduction in the earliest cancer stage, which is what we call pre-neoplastic or dysplastic form, CIN2+, for those of you who know this story. It's the earliest diagnosed stage of what we detect when we do the screening to hope to intervene as early as possible for the treatment of a case of cervical cancer. So there is no question that this vaccine really works, and it works all around the world. It's a matter of carrying it further, extending the reach of the supplies, and having the population and the decision makers in every country really appreciate what we have available for prevention and screening and reduction of illness and death from this set of cancers. So we've talked a lot about cervical cancer, but we've tried several times to point out that this virus infects men as well as women, boys as well as girls, and it's very important, especially for the set of cancers we call oropharyngeal, so the mouth, tonsils, pharynx, upper respiratory area in the mouth and throat, oropharyngeal cancers. These are about 80% in men, and we are very proud to turn the podium over now to Jason Mendelson. Actually, we talked about here about death rates and such. He is an expert on life insurance. We would like to make the life insurers wealthier by reducing the rate of death for the insurance they've provided. Anyhow, he will tell you his story, and he is the founder of SupermanHPV.com.
Thank you. Good afternoon. I had to write down my cancer story because I have a limited amount of time and I didn't want to mess it up, even though it's me. So I hope you appreciate and enjoy the information I'm about to share. 5 years ago this month, I was going through chemo, radiation. I had a feeding tube. I had just had a radical tonsillectomy, neck dissection, so I have a scar that runs from here to here, 42 lymph nodes removed from my neck. And a few weeks before that, I was told that I had stage 4 HPV tonsil cancer, a diagnosis that I had never heard of, nor had I known anyone to ever be diagnosed with it. When I was first diagnosed, I learned that HPV was the most common sexually transmitted disease on the planet, and people were surprised that I was comfortable speaking openly about my diagnosis. I literally had people ask me, "Why aren't you embarrassed?" Through research, I learned that 3 out of 4 HPV, 62% of freshmen in college, and 40 and 60 are the most highly diagnosed decades after being exposed. My believe that I was likely exposed while I was in college, and that at age 44 it presented itself as cancer. On a side note, when I share my diagnosis, one of the most common questions I ever receive is, "Isn't that what Michael Douglas had?" I get asked all the time. And so my answer is, it's the one thing that he and I have in common outside of our love for Catherine Zeta-Jones. Just to tell you that. My plan over the next few minutes is to share my cancer story from my heart, and in such a way that it enables you to understand more deeply why a cure for HPV-related cancers is so important, and why increasing HPV vaccination rates for boys and girls, not just girls, is critical to protect future generations from cancers that are preventable. I also want everyone to understand that while I have a website, Superman HPV, I don't have a Superman complex. I'm not arrogant. It's a name my friends called me Superman during chemo and radiation. I actually forgot to forward this. As an HPV or pharyngeal cancer survivor, I wish the HPV vaccine would have existed when I was a young boy, as I likely wouldn't have been diagnosed with cancer at the age of 44. Let me tell you a little bit about my family. We're extremely close. I often describe us as a blend between the Waltons from TV, I don't know if hopefully you know John Boy from the Waltons, ooh, and my big fat Greek wedding. And then you sprinkle Judaism on top. That's us. At the time I was diagnosed, I'd been married 17 years, now married 22 years. Our boy-girl twins were 12, and our son was 6. We have a family business, and my brother and his family live next door. My sisters and parents live just a few minutes away. Life before cancer was hectic and awesome all at the same time. I was working 50 to 70 hours a week while spending as much time as possible with my wife and kids. Then out of nowhere in April 2014, I felt a bump on my neck and immediately went to my ENT. He put me on 10 days of antibiotics and steroids. He said, in the slight chance that it doesn't go away, we'll immediately schedule you for a needle biopsy and CAT scan. I thought nothing of it because I literally felt perfect, no symptoms. I went to the Florida Keys on vacation with my wife and friends, ran the equivalent of a 5K, flew from the Keys to DC, believe it or not, where I lobbied on Capitol Hill for the life insurance industry. Ironic. I flew home on Wednesday. Thursday had a CAT scan. Friday had a needle biopsy. Monday found out I had stage 4 cancer. I was devastated, truly shocked. I felt perfectly normal with no symptoms but the small bump on my neck. Outside of making calls to my family, I called my 2 life insurance agents and I said, please make sure my life insurance is on automatic draft. I handle the finances, and if I pass away from this cancer, I don't want my wife to have to marry some guy for money, and I don't want my kids to be taken care of by some stranger. So I was honestly worried. I have plenty of this, make sure it's on automatic draft. Did you forward my slide? Yeah. Oh, I thought you already did that. I went, all right, here we go. I made videos to my kids saying goodbye. So let me explain to you how that's probably the worst thing you'll ever have to do. The videos went something like this. One day you're going to get married. I'm not going to be there. This is what's important. I speak to my parents multiple times a day. I was 44, and all I thought was, what advice? Who's giving my kids advice like my parents give me advice forever? My wife's awesome, but I also speak to my parents all the time, so I knew I could, make a significant impact there. Treatment was brutal. It didn't seem difficult at first, but after 5 weeks, I developed third-degree burns in my throat. My saliva was so thick that I couldn't swallow it, which means that I was spitting into a large cup all day long, and when it got full, I would pour it down the sink, and it was so thick that it wouldn't go down the sink. I was gagging and choking 30-plus times a day. I'd go to sleep at night fully hydrated, and I would wake up 2 hours later fully dehydrated. I was not throwing up. I was not sweating. I did not have diarrhea. I didn't know you could become dehydrated without doing one of those 3 things. And the burns were so strong in my throat that they were sucking the fluid from the inside out. It was horrible. I was in bed 18 hours a day for a month. That's me. Now, I will tell you, because I've gotten a little emotional already, but there's only one good thing about being in bed 18 hours a day for a month. I got to watch 7 years of Lost in 2.5 weeks. Horrible ending, by the way. My last treatment was August 11, 2014. It was the best day ever, I thought, until I realized that radiation was cumulative. It's the gift that keeps on giving, and for the next 3 weeks, I got consistently worse. Burns were worse. Saliva was worse. Everything was worse. Today I'm cancer-free, although I do have some lasting side effects from the treatment. I'm fortunate to have regained 85% of my saliva. Many people don't. Although I do gargle every morning in the shower with hot water to loosen the phlegm in the back of my throat. I get Charlie horses in my neck once a day, where if you've ever had them in your calf, I get them here where my surgery was, where I have to pull my neck back and I'm fine. I use fluoride gel trays and Fluoridex toothpaste every day. It's fluoride strong to keep my mouth healthy and my teeth strong, because with lack of saliva, you can have significant problems. And I exercise often to be a role model for other cancer survivors. It's a poem my daughter wrote to me while in high school. I'm not going to read it or I'll cry. I launched Superman HPV in 2017 to provide inspiration and information for those diagnosed and or researching HPV, the HPV vaccine, and HPV-related cancers. I wanted to give people hope and encourage oral cancer screenings. I'm working diligently to give back and save lives through sharing my story. I'm serve on the national board for the Head and Neck Cancer Alliance, where we're working closely with their ambassador program, which is comprised of survivors, patients, and caregivers who share their stories to help others. I'm also involved with the American Cancer Society's HPV Roundtable, working to increase HPV vaccinations. I have approximately 2 to 4 patients, survivors, caregivers from all over the world reach out to me on a weekly basis. I had multiple today saying that I was doing a good thing, that they no longer felt alone. And that's a problem. People feel alone with this, with oropharyngeal cancer, which is tongue, throat, and tonsil. So I put together this 2-minute video. I cut it back for the sake of time. I put it together so you could understand more deeply about my family. I cry at Hallmark commercials. It's me. When you watch the video, what chokes me up almost every time is I picture, what if I wasn't in those videos? What if I wasn't in the pictures? What would my kids have said? So for instance, when you watch them, imagine me being removed from the pictures, and I imagine that my twins who just graduated high school, they would have said something like this had I not survived. I wish Dad would have been here to see me graduate. He would have been so proud. So I put together the video so you can watch it. I have a little comment at the end. And I think I know how to do this because Brandon's awesome. Oh, Brandon. Brandon was awesome.
Those times when you feel like there's a sign there on your back says I don't mind.
My mom
if you
recommended
kick me.
this song to me
Seems
when I
like
was going through
everybody
treatment.
has. Things go from bad to worse. You think they can't get worse than that, and then they do. You step off the straight and narrow and you don't know where you are. Use the needle of your compass to sew up your broken heart. Ask directions from a genie.
Not awesome, but I did learn how to separate my mind from my body so I could be elsewhere.
That's when you learn the truth. If you're going through hell, keep on going, don't slow down. If you're scared, don't show it. You might get out, for the devil even knows you're there. Well, I've been deep down in that darkness. I've been down to my last match. Filled 100 different demons.
People send me their videos from all over the world when they finish.
But the good news is there's angels everywhere out on the street, holding out a hand to pull you back up on your feet. The ones that you've been dragging for so long, you're on your knees, you might as well be praying. Guess that's what I'm saying. If you're going through hell, keep on going, don't slow down. If you're scared, don't show it. You might get out, or the devil even knows you're there. Yeah, if you're going through hell.
My hope Thank you. My hope is that through sharing my story, other parents will be saved from having to make heart-wrenching videos to their kids saying goodbye. Thank you again for investing the time to hear my story. I'm confident that by working together, we can protect families just like mine from HPV-related preventable cancers. Thank you. Thank you.
Well, there are several messages in that experience we just shared. First is that this disease hits men as well as women, and the oropharyngeal area can be women as well as men, and that it is so much more important that we focus much more than this society has on preventing cancers than just counting the cases later, even when the therapy turns out amazingly effective, though quite painful. So, Tamika, you want to make some remarks?
Well, first I want to thank all of you all. I think just as a survivor, this is incredible. I just, I feel that so much is happening, and we're going to do this. And it takes everyone in this room. Jason, incredible. Just thank you so much. And we're not alone. And thank you for sharing your story and everything that you do, because I know it's not easy. In this room, I want you all to know, you attend briefings all the time. I know I come up here for some. I can't imagine how many you attend. But I want you to think about this is something that you can do something about, right? Right now. We don't have to wait. We don't have to think about the future. This is something that we can reach out and touch and grab and make a difference. I think about Lisa, who's not here. I was diagnosed at 25. I almost lost my life at 25. And I'm thankful that I didn't, but I lost my fertility. And it has changed my life in such a way. At 44, I just turned 44 on Tuesday. I deal with so many secondary issues because of my cancer, from lymphedema to bone loss. You heard what Jason has to go through. I saw him here with 2 bottles of water, and I knew why he had them. And, it may look like life is easy for us. We survived, and it's over. The reality is cancer is so disrespectful, and it's so unforgiving, and it doesn't stop for us. But we survive, so we go on, despite of everything. And so I implore you to be involved in some way, to take action, to do something, because this isn't something that we want to do. It isn't something that, maybe it's a pie in the sky and we can try, we can do. And the last thing that I would remind you of, all the stats and everything that you saw today, there are real people behind those stats. Jason is one, I'm one, and is Justine in here? Her mom, and anyone else who's been touched by HPV-related cancers. And so I implore you to do something, because we can do something. Thank you.
Thank you. That reminds us of the Yes We Can mantra. There's such an important closing message for this session, which is that we often have aspirations to understand mechanisms of cancers, to find the real causes, to find new knowledge. It's a many decades process of trying to understand enough to take a first step toward an effective intervention in an animal model. But then mice don't predict so well for humans quite often. And then we finally bring something to the patient. It has to go through many trials and through the FDA. There has to be a company willing to develop and market it. And here we're sitting in a situation where we have the vaccine. several stages of development of this vaccine, already fully approved, magnificently effective. And it's up to us to figure out how, in all our different ways and leverage in this big system of ours, we can get far higher coverage of the population, starting with children, 10, 11, 12. Officially, I guess we're saying 11 to 12 is the highest priority target population. But up through 15, in Australia, they're doing it up to 26. I learned from our experts that yesterday the Advisory Committee on Immunization Practices opened up the possibility in this country, samples available, demand sufficient, that they would recommend as desirable the use of the vaccine up to age 26 in men and women who haven't already been infected. And even for those who are keen to take action beyond age 26. This is a subject that is going to grow because it's a story where everyone can make a positive difference. And we hear exactly how devastating the disease is, even when you finally beat it. The consequences afterwards are complications. Consequences also, by the way, with regard to prevention of cancers, one of the leading risk factors for a new primary cancer in a different site is having had a previous cancer. And it's a message to everyone who has suffered through a cancer and survived that you have to be vigilant about all the parts of the body where we can screen and can self-examine and try to prevent or detect at the earliest possible stage to make a difference. John, I think our time is up. I will ask if there's somebody in the audience who has a question you think we have to hear. I want to commend all of you. I thank our speakers, every one of you, very much. It's been Thank you all for your interest and dedication to the subject. We commend you for staying with us. We appreciate it. Have a good day, and think about how you can help take action on this agenda to eliminate cervical cancer and other HPV-related cancers. Thanks very much.